Right. So today we are going to talk about skin. So skin and related appendages, anything related to the skin or anything slightly changed from the skin, which is originally a skin, but slightly different. So it is a bit naughty of me to say, this is skin, but actually it is a integumentary system. So it is a pretty mouthful word. But now we are talking about system already. So initially we start with the cell biology. So a little bit of cells, a group of cells together with the same function, it formed tissue. And we saw like 4 different types of tissue with our previous lecture, like epithelial tissue, connective tissue, muscle tissue, and nervous tissue. So now we are starting to combine all these different types of tissue. Or we are now starting to combine all these different types of tissue together to form a system. So this is what I get from one of the biology books, what are we? What are we made of? Hey, we are made of 4 different types of tissue: epithelial tissue, connective tissue, muscle tissue, and nervous tissue. But, just so, and actually, if we split all these tissue into different pieces, we are going to get small little cells. So cells, the basic structural unit of human body. But let's say if we just keep banging the cell, splitting the cell again and again, cytology, then we are going to see the what do you call the plasma membrane, cell membrane, inside cytosol, and then inside, we can see the little mitochondria or everything. Okay, let's split. Let's get a better microscope to get into those little organelles. Then we are going to get like little molecules. But what, and then finally become actin. And what actually are we? What are we really made of? So the whole human body. So it is for the anatomist to say, hey, it's easy. It is 4 different types of tissue we are made of. But okay, what are these tissues made of? Okay, they are made of cells. What are these cells made of? Okay, they are like my nucleus, mitochondria, cytosol. And what are these made of? Keep digging and digging into, and then finally we got to this stage. A human body is made of loss of oxygen, loss of carbons, hydrogen, nitrogen, and a few other stuff. That is what we are really made of. So the most important thing is carbon, isn't it? And water and oxygen. So that is a human being. But okay, we are anatomists, we take everything for granted. We are not going to think that far, and we are just going to stick with the human body as much as we can. And now we start talking about the skin, which is the system, which is, in other words, it is called integumentary system. So the skin. So this is the first lecture about the skin, about which is skin. So the skin. So if you pull yourself, if you pull on your body, the skin, hey, it is really nice. It's good to touch yourself. It's good to touch the soft skin, nice skin. And what is it really made of for the anatomist? The skin is made of like the outermost, the skin, which we can feel, and another layer structure, which is what we call hypodermis. It is a Greek word. Hypo means below, hyper means above. So hypodermis means just below the dermis. Dermis is the part of the skin. The skin and hypodermis. And the appendages like our hairs, our nails, our sweat gland, sebaceous gland. And that makes up the integumentary system. That is what we are going to talk about today. And of course, I hope we have time to talk about some disorders of the skin. So the skin, strictly speaking, skin consists of epidermis and dermis. Plus, underneath the dermis, we said hypodermis. Hypo, Greek word, it is hypo mean below. Hypotension mean low pressure, mean like high blood. If you have high blood pressure, it is called hypertension. Hyper mean above. Tension mean increased tension in the blood vessel. So hypodermis, just beneath the dermis. And we talk a little bit about skin color. Because this is United States, hey, it's California, there are many different races, you know, like white, black, yellow, pink. So why do we get these skin color? Nobody knows, but yeah, there are a few little reasons we understand why our skin is dark or why our skin is a little bit light. And we talk about nail, hair, we have, and the sweat gland, and the sebaceous mean like little sebum producing sebaceous gland. That's what we are going to talk about today. So if you see this photograph, that photograph is from the textbook, you know, what are we seeing? Like the whole hand. So again, like in anatomy, on this surface, it is the dorsum or posterior. We don't usually say posterior, dorsum surface of the hand. And on this side, it is the palmar surface of the hand. Yeah, so I believe you get it. Dorsum of the hand and palmar aspect of the hand. So this is the palmar aspect of the left hand. Yeah, so this is the left hand. This is the palmar aspect of the left hand. What is noticeable? The whole palm is pink and red. That is pretty obvious, isn't it? If you look at the fingers here, it's all pink and red. And what do you see here? You start seeing the blisters and bullae. So this is the burns, you know, burns mean like damage injury to the skin. That is what we call burn. So this area is just red. There is no blister. This area, we can see the blisters and bullae. So that is second degree burn. So this is just like getting red and pink. The color change, that is very much first degree burn. I believe we all have this problem, like when we are cooking or doing something, doing barbecue, and then we touch it and then our fingers get red. I mean, if it is a little bit deeper burns, if it is a deeper burn, then we will say we got a few little blisters here and there. So let's say, you know, if the burn is too much, too deep into the skin from outside, then we get a charcoal. Like there is no more blister, no more redness. It is just like white out, dark. That sort of color is more like leathery, which means it is fully cooked. So this is the third degree burns. I believe, you know, once you start in your life in a medical environment, in the hospital, emergency services, you will start seeing these injury off and on again and again. But of course, you know, especially this is far more common than this sort of burn, because this is something we see every day, and it has happened to me, and I believe it might have happened to you, you know. This is a very common problem, first degree burn, second degree burn, and this is the third degree burn, which is really rare for us to see unless get in a really disastrous fire. So I believe we all remember this 2020 California wildfire. I hope this sort of extent will not come back again, and loss of fatalities as well. And this happened, you know, nearly every year. So what is a burn? Burn is a thermal injury to the skin or body tissue. You know, also what is the difference between burns and scald? A burn is a thermal injury caused by direct heat or chemicals or electricity or radiation. Scald is more like a hot liquid steam So like if you're boiling something and if you go on top of that boil steam, then it is a scald injury. But whatever it is, these are the thermal injury to our body tissue. And we say first degree burn, second degree burn, third degree burn. We have seen the difference. First degree burn is just a little bit red and not much. Second degree burns, you are start seeing the blisters, and which is painful as well. First degree burn, which is painful. Third degree burn, you see the charcoal. It is completely white out, black, dark, and it's bent, it's gone. We lost all the structures we have in that particular area. So what is first degree burn in detail or in anatomical term? It is only to the epidermis layer of the skin. What is second degree burn? It has thermal injury to the epidermis and goes slightly deeper to the part of the dermis, partial dermis. It hasn't gone into the hypodermis yet. So let's say our skin has epidermis and dermis. Underneath the dermis, we have the hypodermis, which is also called superficial fascia. And then deep fascia, and we will have muscle. So the first degree burn is just damage to the epidermis. Second degree burn will be extending into the dermis. And third degree burn it's completely gone. Both epidermis, dermis, subdermal layer, and might have gone into the muscle. So it has the third degree burn, it has burnt and charcoaled everything in that particular area, which means it has burned the nerve and blood vessels, which means third degree burn, they might not be painful because all the nerve sensation fibers, they are all damaged. So this is about burns, which is a thermal injury. When we are talking about to the skin, of course, it is the thermal injury to the skin. It could be in a just direct heat form as a chemical, electrical, or radiation, which is called burns, which is this thermal injury could be like a liquid form, which we call scald. And I believe now you can relate the first degree burn with just to the extending to the epidermis, second degree burn extending to the part of the dermis, and third degree burn is completely deep down, epidermis, dermis, which is skin, and then just below the dermis, hypodermis, and might be going deep into the muscle as well. That is third degree burn, which is pretty charcoal everything. It has burnt the nerve, and therefore there is no more sensation. Gone. So this is something brief thermal injury to the skin, because we are going to talk about skin. So this is the way, you know, like first degree burn, I believe it's just pink and painful. Second degree burn, you got blisters now because it is going into the dermal layer, and third degree burn, completely charcoal. There is no more sensation. So how do we define to a patient what is the percentage of burns? Because the burns percentage is related to the outcome and survival of that person. So if we are in an emergency room, and if we have a patient who is caught in the, let's say, house fire or wildfire, and if the patient has like about, let's say, 50 degree burns, 60 degree burns, it is highly likely that this patient is not going to survive. So let's say if we have burns only in our fingers and the palm, then we know that this patient is not going to die unless we are reckless. So that is the way, you know, the percentage of burns on our body is related to the patient survival. And that is why it is important to know it is important for us to assess what is the percentage of burn in this particular burn patient. So how do we know that, you know? So let's say if it is for me, it is my palm of my finger. If it is for you, it is palm of your hand. If it is for a little baby, it is the size, it is the palm size of that little baby. So that is the 1% of your body, let's say. So if you look at this person, if we look at this person, the front of the thigh is 9%. So which means we expect if we take this palm and put on the front of the leg, and it will be like about nine palms breadth. So the same thing like 9, 9. On the back of the leg, another 9. On the back of this leg, 9, 9. So gradually, if we add for our upper limb, arm and forearm and hand, it is 4.5. So at the back, 4.5. So one upper limb is 9%. The other upper limb is 9%. The anterior trunk is, chest is 9 and tummy is 9, so total 18%. And the same thing like to the back of the body, it is 18%. And finally, you know, like face at the front, 4.5%, at the back, 4.5%. Completely the head and neck will be about 9%. And if we calculate, it is all like 99%. And the perineum like genitalia, extended genitalia, and the back anus, it is 1%, which means like, you know, it makes sense because if you put your palm and if you cover yourself around your perineum, it is 1%. So that is perineum is 1%. So that makes 100%. So let's say whenever you have to assess a patient, you take the surface area of the palm of the hand and just like take that area on the patient, and that is the way you assess what is the percentage of pain in that particular patient. So total 100%, perineum is 1%. So that is the way we assess, because we need to assess it. Number one, how deep it is, and number two, how widespread it is damage to the body. And that is the way we can judge how to resuscitate this patient. So this knowledge is really important. And who started this? This is a gent, a plastic surgeon from Edinburgh, Scotland. And his name is Wallace, and that is why we call Wallace rule of 9. Yeah, Wallace rule of 9, and that is the way we assess the back injury. And this Wallace rule of 9, this Wallace came from this gentleman who is from Edinburgh, Scotland, and he was the plastic surgeon who started to say this. So now let's go back to what we really have to talk about, which is skin. We understand, you know, thermal injury to our skin to some extent, and we know how to assess what is the percentage area of the surface and how deep the tissue is damaged. First degree, second degree, third degree burn, but Wallace rule of 9. And now let's study about the skin. So why do we need to study? Why is it important? Hey guys, I think it is the best structure you can have in your life. You know, it is waterproof. Your skin is waterproof. Yeah. If you have a shower, the shower water will not go inside into your body. You can go in the rain. It's fine. You can swim. You can float in water as long as you like. Your body will not swell up with water. It is so much waterproof. You can believe this. That's number one. And number two, washable. Like if you can wash it daily, you can wash your body daily, and it is fine, you know. Like if you wash your clothing, like doesn't matter how much you give, how expensive it is, it will worn out at some point within like 2-3 years, but the skin will live with you for the rest of your life. So the skin is important. And it has an ability of spontaneous repair, which means like if you scratch it, if you puncture it, it has a high potential to heal on its own. Yeah, don't abuse it, just use it, and it will look after you. Yeah, spontaneously. It is stretchable. Of course, you notice that, you know, when someone has a pregnancy, the belly has expanded such a large size. But when the baby is delivered, it's just trying to go back to pretty much normal. So it is stretchable, and it will stay with you for the rest of your life. And it is really important. And it is an organ which is the largest organ of the body and which contributes about 7% of the body weight. So hey, so this is really important organ in our body, and I want you to appreciate that. I want you to look after this. It will look after you for the rest of your life. Of course, you know, when we get really old, like 80, our skin become really thin, really fragile. It can damage so easily. But if we think about that, you know, the skin has served our body the rest of our life, and it is really important. So let's go to the next slide. So we said the skin is waterproof, washable. It has spontaneous repair. It is stretchable. It is for life. It is the largest organ in our body. So the outermost layer of the skin, we said epidermis. Deep to the epidermis is called dermis. Combination of epidermis and dermis is what we really say in layman term, is skin. And underneath the dermis, we have a layer which is called hypodermis. So hypo, below the dermis. So epidermis is made of epithelial tissue. So epithelial tissue means there are 4 types of epithelial tissue. Well, not really. There are 3 different types of epithelial tissue, like squamous epithelium, cuboidal epithelium, columnar epithelium. And depending on how many layers we have multiple layer, striated, simple epithelium, and we have the pseudo-stratified epithelium. On top of that, we will have the transitional epithelium. So the skin epidermis is made of one of the epithelial tissue, which is the squamous epithelial tissue. So yes, of course, the squamous epithelial tissue, which is pretty thin and squamous flat cell. So on its own, it is not going to be useful for the protection. And therefore, we put multiple layers of flat cells. So epidermis is made of multiple layers of squamous epithelium, and therefore epidermis is stratified squamous epithelium. On top of that, there is a layer called keratin. So that is a waxy layer cover. So that is why the skin is so much protective against anything. The deeper layer of the tissue, you know, as we know, epidermis will sit on another tissue, and usually it sits on the connective tissue, which is the areolar connective tissue. And I want to remind you, there are 4 different types of connective tissue, which are areolar connective tissue proper, cartilage, bone, and the blood. So we are going to use connective tissue proper for the dermis. And hypodermis is like a little layer, you know, which is pretty much made of some loose connective tissue and fat. So this is hypodermis. Hypodermis is made of, again, connective tissue, loose areolar connective tissue plus fat. Fat is in our anatomical term, adipose tissue. So hypodermis is made of loose areolar connective tissue and adipose tissue, so which is not a very strong layer. So what do you think, which is the strongest layer of these three? What do you think?
Would it be the dermis?
Yes, dermis, it is the connective tissue, which is strong, which has got lots of fibrin, collagen, elastin, and therefore the dermis is very strong. Epithelial tissue is small little squamous epithelium sitting on top of each other. So there is no strength. So that's why, when we are closing the wound, like after the operation, when we close the skin, we really have to stitch properly to the dermis or subdermis, just at the base of the dermis region, to get the strength of that wound. And epidermis closure is just like, you can even put a little glue on top, or you can put a fine stitch. There is not much strength for the wound. The wound strength comes from your stitch, where you put your stitch in the dermis layer. Hypodermis, forget about that, because there is just fat. Some of the fat in body temperature might be a little bit liquidy, and there is no strength at all. So make sure whenever you close the wound, like you might want to be a doctor or a surgeon, or you might go to the physician assistant, or you might be helping in the operation room as one day, like in about 3, 4, 5 years, whatever you do. When you have to close the wound, you have to really close the dermis layer carefully. So that is the importance of this dermis layer. So now we have seen this picture, what we learned from the very first day. We are talking about superficial and deep, isn't it? Superficial and deep mean outermost is most superficial. Deep means the deeper go into the body. And outermost layer is epidermis. Deeper to the epidermis is dermis. Combination of epidermis and dermis is what we call skin. And just below the skin, just underneath the skin, deeper to the dermis, is a layer called hypodermis. Hypodermis, as we say, it is not much. It is adipose tissue, fat globules, and loose areolar connective tissue. There is no strength at all. And then underneath which is what we call the hypodermis, is what we say as superficial fascia, in other words. Some books will describe hypodermis as superficial fascia, and deep to the superficial fascia is deep fascia, which has some strength. And underneath the deep fascia is muscle. So that is, that is the coming from superficial to deep. That is about our skin. So let's take a piece, let's take a chunk of our skin and look under the microscope. This is really nice diagram, and I want you to get a photographic memory, because the problem with the anatomists or those specialties which has to base on the anatomy, like for something like surgeon, what makes an operation quick? Operation quick means you have to plan what you are going to do for that operation. That's number one. And number two, you have to know the anatomy so that you know where you are. Like once you start operating, you are not damaging what you do not want to damage. You know your anatomy. Only then you can progress quick. Like if you start making a cut on the human body and then you start damaging this and that just because you don't have good anatomy knowledge, which means your operation is going to take a long time with multiple complications. So for a surgeon to make a quick operation is number one, planning, number two, knowing the anatomy, and you need to have plan A, B, C. If you want to do it, you can do it, If not, you need to have second plan. It's just about life, you know. You need to be aware of where you are and what you are going to damage. The same thing, if you're going to make a cut on the skin, you need to understand the skin. And this is really, this lecture is really important for that aspect. So this is the epidermis. So it is not very thick, and epidermis is made of just squamous epithelium, which is on its own really flat cell, not much for the protection. So for us to get the protection, we put one squamous epithelium, another squamous epithelium, another squamous, multiple layers of squamous epithelium. This is the epidermis. And look at that. What is that ratio between the epidermis and dermis? Dermis is really thick structure, and epidermis is, the thickness of the epidermis is not much. And another thing is epidermis is like a squamous which is shedding every day. So like, you know, every day we are shedding skin scales everywhere. And dermis is a really thick and leathery. So when we buy leather like leather belt or leather wallet, that is what we get, which is dermis layer. And as we say, underneath the dermis is hypodermis layer, which is just some collagen fiber, loose areolar connective tissue, plus lots and lots of fat globules. We are not going to say fat, we are going to say adipose tissue, because we are studying anatomy. So lots of adipose tissue with loose areolar connective tissue, that is hypodermis. And look at that dermis, the thickness and the strength and the content, the richness of this dermis. And if you look at the epidermis, there is not much here. So your sweat gland, your hair follicles, and your blood vessels, they are all, and the nerve here, look at that, how busy it is, how rich it is. Your dermis is so rich, and that is what we like, yeah? So even for the dermis, we can subdivide it into papillary dermis and reticular dermis. Papillary dermis is close to the epidermis, and reticular dermis is deeper. Yeah, look at the difference again. Papillary dermis is not very thick, and reticular dermis is pretty thick. And combination of papillary dermis and reticular dermis is what in combination we call dermis. So all our hair follicles, all our nerve endings, all our sebaceous gland, all our anything, blood vessels, veins, arteries, they are located in the dermal layer. So dermal layer is really important. Now, so the skin, we said skin is protective, skin has sensation. If we touch ourselves, we know that it's being touched, and it's involved in the temperature regulation, it's involved in the vitamin D protection, and it's involved in the excretion. So guys, the skin is so important to us. Therefore, you know, if we burn our skin, if there is any thermal injury to the skin, we are going to lose all these functions if we are not lucky enough. And how can we survive if we lost like about 50–60% of our skin damage? And if we are losing in these, we are not going to survive. That's why, you know, burns patient, if they have large area, especially when they become deep, they don't survive, they die. So protection, what sort of protection does it give us? It gives us physical protection, and it gives us biological protection. So, you know, the COVID-19 virus cannot go through the skin. That's lucky. If the COVID-19 virus can go through the skin, then we have to wear all the hoods for the whole body, because it is just respiratory. So which means like we can protect our nose and mouth, and that's it. If the COVID-19 is permeable to the skin, that will be a disaster. So it has got physical protection and biological protection. So physical protection means like ultraviolet light or like water. Biological protection like microorganisms. And on the physical protection, I have to say it's cushion as well. Because, you know, if you look your skin on your palm, or if you look on your skin on the sole of your foot, look at that, that skin is so thick, and that is equivalent to your Nike Air, yeah, Nike Air shoe. Like it's so soft, you can walk on your sole of the foot. You might not be able to run, you can walk on the rough surface, and that's fine. You know, those people in poor country, they do not have any shoe, not even like Nike Air or Air Max, doesn't really matter. They are walking on their sole, and that sole skin is giving them protection and cushion. So if we think about that, you know, I mean, being in this country, we are privileged already, because you can buy any shoe you like, it's on the market. They are all affordable. So sensation, the skin has sensory receptors. So for temperature, touch, pressure, pain. So yeah, I believe we all understand that, you know, external environment, Vegave, 12 o'clock, it's so hot. Our skin knows that. Touch, if I touch you, you will know that, hey. Pressure, if I press it, you will know that. And pain, it's painful, you know that. So these all are important, because if we lost our touch and pressure sensation, like a stroke patient who is lying on bed for a long time, and on that side, you know, they don't have any pressure or touch, or they cannot move, that skin will die, isn't it? Because there is no more blood flow, or gradually lack of blood flow. So, you know, the sensation is really important. Temperature regulation, again, like for the temperature regulation, I mean, the skin has a lot of sweat glands. So these sweat glands, if the environment is too hot, sweat gland will secrete sweat. Sweat means what is inside sweat? You know, let's say if we are so sweaty, if we just wipe our forehead and get a drop of sweat, and if we analyze, what do we get? What do we have in our sweat? Can somebody bullshit me, please?
Sodium.
Yeah, sodium. And keep going.
Water.
Water, yeah, of course, loss of water, isn't it? It's water. And have you ever licked your
Sebum.
eh?
Sebum.
Sebum, yes, sebum is different. Sebum will come from sebaceous gland. They will come
Salt. Salt.
Salt, yeah, is that what you say?
Okay.
Yeah, salt. So what is salt? It's sodium chloride, isn't it? So sometimes, you know, if we lick ourselves when we are sweating, it's so salty. Why is it so salty? It is sodium chloride. Basically sodium chloride plus loss of water. You go, it's like Coca-Cola. They sell us water, they give some gas, they put some sugar, and they give some color. That is Coca-Cola. So the same thing, sweat is loss of water, sodium chloride, might be a little bit of urea, and that's it. So, but you know, this sweat, we can see it will cover, it will just like, you know, all body, most parts of the body have sweat glands, and it will come out and it will cover with little water. That's why it makes us cool during the summertime when it is really hot, temperature 90, 100. But we don't really appreciate this sweat, you know, as water, as like we are having a shower. It's like a mini shower, isn't it? Mini shower. And then this mini shower, we lost water. We lost water from our body. And this water loss is what we call insensible loss, because that is something we didn't appreciate. Of course, if it is too hot and we see our sweat all over our body, we know that, hey, we are losing some water. But in a day-to-day life, you know, we don't really appreciate it. It is just about temperature 70, 80, and we just walking around, might be a little bit of sweat, just blown away by the air. And that is, we are losing some water. That is what we call insensible loss. So let's say if you are walking in an intensive care unit, ITU or ICU, and for that particular patient you are looking after, so if you want to make the fluid balance, like water intake to the patient and water output of the patient, you don't forget insensible loss for that person. So the sensible loss is something you can calculate, like water for the urine output for the patient, feces for the patient, and if they are bleeding, blood loss from the patient. And insensible loss is something the environment. That's why, usually intensive care unit, they have air conditioning, so the calm the patient down, and there is not much insensible loss they have calculated. But at least you have to for us, you and me going out daily all the time, we have to give about 500 ml. So 500 ml of fluid for insensible loss. That is like a very average insensible loss. So that's for the temperature regulation. That function is provided by the skin. So it also has like some endocrine function, like vitamin D protection. So what does it do? The skin is exposed to the sunlight, ultraviolet light. This ultraviolet light come and hit on the skin. And then in the skin, we have an enzyme called 7-dehydrocholesterol, and this will change into pre-vitamin D. This pre-vitamin D will go to the liver, will go to the kidney, and then we get vitamin D. It's clever. It's clever. Yeah. So that excretion, because salt, as we say, salt, sodium chloride, water, urea, through the sweat. And because of this excretion, we can regulate our temperature as well. So that is a function of our skin, and it's really, really important. So we said skin has physiological, biological function as protection. We got sensory receptor for the sensation. We got sweat glands and capillaries for temperature regulation. We got vitamin D protection from the epidermal cells, and we can do excretory function. That is our skin, guys. So it is important for us, for the clinician, whatever you do in the clinical environment, and even for the layman person, you need to understand your skin, because your skin covers your whole body and protect you from the external environment. And the skin is made of epidermis and dermis. Full stop. And underneath the skin is the layer called hypodermis, which is made of mainly of adipose tissue with some loose areolar connective tissue. And underneath that hypodermis or superficial layer, we have deep fascia, and underneath we have our muscle. So skin is made of epidermis and dermis. Epidermis layer is more superficial to the dermis, which is deeper layer. Epidermis layer is made of squamous epithelium, but it is multiple, and therefore it is a multiple squamous epithelium layer. In other words, stratified squamous epithelium lesion. And dermis is made of connective tissue proper. And I remind you, connective tissue, there are 4 types of connective tissue. Number 1 is connective tissue proper. Number 2 is cartilage. Number 3 is bone. And number 4 is blood. So this one form of connective tissue proper, makes dermis. And it is keratinized. I mean, keratin is just fibrous protein wax. It's nothing, this keratin is nothing. Because, so we said, the epidermis is made of multiple layers of squamous epithelium. In between the squamous epithelium, we put keratin cells, those cells which make keratin. Like it is just making bread, When you make a bread, you put flour, might be egg, might be a little bit baking powder, and you mix it. So in top of that, if you put some resin in it, you got a bread with mixed resin. If you put some nuts in it, you got a bread with multiple nuts. So the same thing, like in between these multiple squamous epithelium, you put a little bit of keratinocytes. The cells called keratinocytes. Keratinocyte means cell which produce keratin, and these keratinocytes will produce keratin, and this keratin will gradually get more and more, and it covers on top of the simple squamous epithelium, stratified squamous epithelium. That is the keratin layer of the skin. Of course, keratin layer will go outer to the external superficial part, most superficial part of the squamous epithelium. And the same thing like for the dermis, it will go deep, deep, deep. And then it will just bind the whole entire body so that you are a little bit more good looking. If we do not have dermis, if we lift up our arm, it will just all plumb down like a bulky light. So the dermis just bind the whole body together. So epidermis has keratin plus stratified squamous epithelium. Epidermis contain, so on top of this squamous epithelium, multiple layers of squamous epithelium, we have another 4 types of cells in the epidermis. So epidermis is made of multiple layers of squamous epithelium, and you put a little bit of keratinocyte, you put a little bit of melanocyte, you put a little bit of tactile epithelial cell, and you put a little bit of dendritic cells. So that is the final product of this epidermis. So if you want to make epidermis, you take lots and lots of squamous epithelium, and on top of that, you put some keratinocyte, melanocyte, tactile, dendritic. Then you got the epidermis. Yeah. So the name tell who they are and what they are going to do. Keratinocyte, cyte means cell. Keratinocyte means the cell which is going to make keratin. So if we have a lot of keratinocyte and they are making a lot of keratins, we have a very thick keratin layer. If we do not have a lot of keratin, there might not be much keratin, then we have very thin layer of keratin. Then keratinocytes are most abundant cells other than the squamous epithelium. And melanocyte, again, like by looking at the name, we know what it is. Cyte means cell, melano means melanin producing cells. Tactile is so obvious, it's just touch cell, tactile epithelial cells. And dendritic cells, these are the small little cells, like which is like a policeman, you know, CHP, California Highway Patrol. It's just wandering around or sitting in the epidermal, in between these squamous epitheliums, and it's just waiting for the foreign invasion, like foreign protein, antigen, coming. This dendritic cell will go and solve that problem to a good extent. So the epidermis has multiple layers of squamous epithelium, plus we have another 4 types of cells. So look at that. What are we looking at? We are looking at the same picture again and again, epidermis, dermis, and hypodermis. And so these sensory nerve endings here, and the blood vessels here. Look at small little muscles here, and the blood vessels and nerves here. So when you finish this lecture, like, you know, I want you to take about 15-20 minutes to go through the textbook and look at this diagram again, and I want you to appreciate. So that's the way, you know, we try to remember things, because anatomy is just like a building blocks. You need to have this knowledge, and again, like it is very straight. You have to remember this. Only then you can make another block. So blocks after blocks after blocks. So sometimes you have to swallow it with some basic understanding. Like, so if you pick up all the knowledge and terminology, then you can bake, and then only then you can understand and expand your knowledge. So I want you to go back at some after the lecture to look at this diagram. I believe I will make some questions out of this diagram as well. So yeah, this diagram is really important. So as we say, the skin, which is made of epidermis and dermis, we are now talking about epidermis, and epidermis is made of epithelial cells, which are squamous epithelium, stratified, multiple layer, plus the cells those are distinct to the skin. Those cells distinct to the skin are keratinocyte, melanocyte, tactile, and dendritic cells. Now you got it. So let's say, if we take that skin, take the epidermis, we take epidermis from someone else, and let's look under the microscope. And usually we will see 5 layers. So we will see 5 layers, which are stratum basilae. Stratum means, it is a Latin word, stratum, it's a layer. Like the earth layer it's also called stratum. It's a Latin word, stratum. Basilae, or whatever you say, basilae. So it is a basilae, it means it's a base layer, most deeper layer of the epidermis. This is what you are seeing under the microscope. Yeah, stratum basilae. So yes, it is the most base layer. Stratum spinosum. Spinosum means you are going to see some spinous process structure in this layer. Stratum granulosum, there you will see like little bit granule-like structures. Stratum lucidum. Lucidum means lucid, empty, clear, lucid, like for those psychiatric patients, or for some patients, for those who have head injury, like hit the head, lose consciousness, and then regain consciousness again before they go back into losing their consciousness again. That is what we call lucid interval. Lucid interval means clear mind or empty, like clear, lucid. So this layer is going to be pretty transparent layer, stratum lucidum. And stratum corneum. Corneum means corn, like horny layer, like big hard, thickened layer. So these are the layers of the epidermis from base to the most external environment outside the skin, which we can feel. So the skin is made of these cells. If you look under the microscope, you are going to see these. If you look under the microscope for the epidermis, you are going to see these layers. So that is what you're going to see. I got this diagram from one of my colleagues. The way she tried, I'm not sure where she got it or the way she tries to remember. So these different layers is a Californians like girls in string bikinis. If you can remember that phrase, Californians like girls in string bikinis. Yes, we like girls in string bikinis, but I don't think I will be able to remember this. Californians like girls in string bikinis. Instead of that, I might just be a little bit dull and just pick up, hey, at the base layer is basally, and then from the base, it will become like a little spinous processy. So it is a spinous stratum spinosum, and then more like granule-like structure, granules, lucidum, lucid, clear. You are not going to see much here. It is nothing much here. You can only see the red line, lucidum. It is more like clear structure. And corneum, corn, like thick, hardened structure, stratum corneum. It is more like dead keratinocytes. It's nothing more. There is no more proper cells. It is only the dead cells layer. So stratum corneum. So whatever it is, for the sake of anatomy class, I want you to remember these 5 layers: basally, spinosum, granulosum, lucidum, and corneum, and the dermis. So if you look at so now you are looking in the microscope and you start seeing these sort of structures. And this, you can see the dermis. It is so easy. Why will you say this is dermis? Okay, can somebody tell me, please? Why will you say this is dermis and this is epidermis? What is the difference? If somebody tell me, I will give you a break. just say something. Why will you say this is dermis and this is epidermis? Okay, if you don't say, I will say it. Because epidermis is made of epithelial cell. It is very cellularity, isn't it? Dermis is made of connective tissue cell. It is not cellular at all. It has got a lot of matrix in it. And therefore, you can say this is the junction between the epidermis and dermis. Right. So epidermis and dermis, and you see multiple cells here. And if you look at the stratum basale layer, it's lots of cells because you can see very thick, deep, dense purple layer. And now gradually becomes a little bit sparse and sparse. And finally, when you go to the stratum corneum layer, the stratum corneum is, there is no cell at all. The cells are already dead and dying cells of multiple layers of keratin. So yes, so stratum basale, stratum spinosum, stratum granulosum, stratum lucidum, corneum. So these are the features. The cells they have, stratum basale, lots and lots of cells, tactile cell, melanocyte, and lots of keratinocytes, which are rapidly dividing. Spinosum, spinous-like extension of keratinocyte. The cells, keratinocytes become a little bit projecting here and there, like spinous-like. And you start seeing the dendritic cells. What are these for? Dendritic cells, they are for the policeman. And stratum granulosum, mean you can see the keratohyaline and keratin granules, lamellar body, and which is waterproof. This granulosum layer has glycolipids, which will prevent water. And stratum lucidum, starting from lucidum, the keratinocytes became dying, gradually dying and clear, getting clear. So this stratum lucidum is only in the thick skin, like our palm of our hands and sole of our feet. And stratum corneum, it is just like completely dead cells of keratinocytes, and they are shedding away every time, all the time. So only the thick skin, like the skin of our palm and the skin of our sole, have stratum lucidum. In thin skin, like our skin of the arm or forearm or tummy, we do not have stratum lucidum. So now we have two types of skin, thick skin and thin skin. Thick skin is on the palm of our hands and soles of our feet. So thick skin and thin skin now. So this is what it is all about. All right, guys, it's about an hour. So what I would do, I will give you about 50 minutes break. So we will meet at 11:15. So go away, have a break, have a fresh air, but please do come back at 11:15. Is that all right?
Yes.
Okay, thank you.
Yes.
So please do come back. Yeah, don't go away.
Thank you.
Right. So epidermis and dermis, which makes skin, if you look at that, we know we have 5 layers in thick skin and 4 layers in thin skin. And these are at the base, stratum basale, and then become stratum spinosum and granulosum and stratum lucidum. Lucidum is look at that. This is a very thin yellow, pale purple, not purple, orangey color. There is nothing in it because the cells are starting to die out already. And finally become corneum, like a cornu horn, hard, thickened. There is no more living cell at all. But the stratum basale is so much thick and dark with the nuclei because the cells are proliferating. Their cells are proliferating in that area. And that's the epidermis. And dermis, we know that we can divide dermis into two layers, papillary dermis and reticular dermis. Papillary dermis is thin and reticular dermis is pretty thick. And papillary dermis, if you look in this picture, hey little baby. So papillary dermis project into the epidermis like a finger projection, like ridge as a ridge, which increase the contact surface between the dermis and the epidermis as well, just because it is projecting into the dermis. So it is something like a grip to hold on each other, as well as it increase the blood diffusion function from the papillary dermis into the epidermis. That's why the cells closest to the dermis are rich, and the cells farther away from the dermis, like become inland, is a little bit dry, and cells are dying out. So the nutrition comes from the dermis, and we know that epithelium cells, they do not have direct blood supply. They get diffuse nutrition from capillaries through diffusion. And this is what it is about. And if we got this microscopic slide, and we know that this is which is epidermis and which is dermis, because dermis is the connective tissue. It is a connective tissue, like it's a seal of the matrix and a few little cells. Epidermis, there are multiple cells here. So that's all about scheme. So let's say, what I want you to do, I want you to have a look in the textbook. What has written here, some peculiar points about each and every layer, like stratum corneum, granulosum, spinosum, and then stratum basale. So yes, that is a little bit, look at that here. At the stratum, this pink stripe, this must be the connective tissue, which is the dermis. And at the base, at the junction between the dermis and epidermis, we have sensory nerve endings here. And melanocytes are embedded in the base of the epidermis. Yeah, then this keratinocytes will gradually expand and go and project into the outer layer of the epidermis. So now let's talk about dermis. Dermis, we said it is a connective tissue. Connective tissue means cell and matrix and ground substance. Cells consist of fibroblast, chondroblast, and the matrix is made of collagen fibers, elastin fibers, reticular fibers, meshwork, and ground substance, glycoside, aminoglycan. And this connective tissue is connective tissue proper, one form of connective tissue, and this is the height or leather equivalent. Connective tissue means cell and matrix. The cell, fibroblast, macrophage, mast cell, you know that already. Matrix means collagen, elastin, and reticular fibers. So this is from our textbook again. You have seen this diagram already. If you forget about that, just take like 2-3 minutes to give yourself to look at this diagram again. This is connective tissue proper, which can be divided into loose connective tissue and dense connective tissue. When we say regular, irregular means reticular dermis, and adipose tissue, which we find in the hypodermis, is loose connective tissue. So to make it short, the skin is made of epidermis and dermis. Epidermis might be 4 or 5 layers, depending on which part of the skin. The skin on the palm of the hand and sole of the feet, they have 5 layers. The skin on the other part of the body has only 4 layers. They do not have stratum lucidum. And dermis is divided into papillary dermis and reticular dermis. Papillary dermis is about 20% and reticular dermis is about 4 times thicker. And they are both connective tissues. So dermis, deeper layer of the skin, which is underneath, deep to the epidermis. Papillary dermis and reticular dermis, 20%, 80%. Papillary dermis is areolar connective tissue, and this is reticular dermis is dense connective tissue. So I'm going to show you the same diagram again, same figure. So papillary dermis is, reticular dermis is irregular, dense connective tissue. Yeah. So reticular papillary dermis is loose connective tissue. So areolar connective tissue. So finger-like projection, as we have seen, like the dermis finger-like project into the epidermis to the stratum basal layer, so that it has good anchorage to the epidermis, so that it doesn't lose the grip, and it has give more like a surface area for diffusion. So the dermal ridges extending into the epidermis give us the dermal ridges in the palm and sole by pushing the epidermis. That is what we call epidermal ridges. So epidermal ridges, like if we look our fingerprint, these are the crest and valley, isn't it? The trench and valley. So it's just like, it's like that if we look cross section. So these bulky points are being, the underlying dermis pushing the epidermis. That makes these are what we call epidermal ridges. And in the crest, there are sweat pores. That's why if we touch something else, our sweat in the crest, in between the ridges, the epidermal ridges, they leave the fingerprint. So reticular dermis has lots of collagen, elastin. They are running in a very specialized function, like in our neck, these fibers are running circumferentially here. In our arms, they will be running longitudinally. So they have a very particular way of running, which give us the cleavage line, So like if we neck, the skin cleavage line is like that. In our tummy, it will be like that. And in our forearm, it will be along the forearm. So that cleavage line are also very useful when we are doing surgical operation, like when we make a cut on the skin, these cleavage line, if we follow along the cleavage line, we have a much better scar and there is less chance of wound gaping. So now you got 2 more important things, epidermal ridges and cleavage line. So what is it all about? So these area, they become bulky and being bumped up to the outside because dermal ridges are pushing into the epidermis. So because this area is pushing, this area become trench or valley. And here the sweat glands exit in this area, which will give you the fingerprint. That is the way we, like foreign forensic science, we got the finger ridges, which is very identical to individual person. So that is the forensic importance. And these are the cleavage lines, like around the neck, the cleavage lines are like that. That's why when we do an operation on the thyroid, we do not cut the skin longitudinally. We cut the skin like a cleavage line so that we have a much better scar. So that's why, after thyroid surgery, the skin surgical wound is so difficult to identify after 3-4 years because it is going along the cleavage line. The same thing, on our body, it is going like circumferential, and along the limb, it is going like a oblique, and in the leg, it is more like a longitudinal fashion. So that is the way our cleavage line. But why do we have cleavage line? Because of the connective tissue like collagen, elastin, they are running in this direction. So that is the importance, clinical application. So if we look at that, like as we saw in the previous picture, the skin line, cleavage line in our tummy, like epidorsal is a little bit more circumferential. The here is a little bit big. And if we make a cut on that area, that sort of scar we are going to get. It is a little bit big and ugly scar, and there is even, the scar has been stretched already, because if we make a cut this horizontally along the cleavage line, we are going to get a much better scar. That's for sure. So let's say when you become a surgeon, if you are doing an operation on somebody, if you can just follow along the cleavage line so that you are splitting the collagen and elastin fibers rather than you are cutting the collagen and elastin fibers. Your patient will have a very ugly scar. Your patient, the chance of wound gaping is big because it is stretching away to each other. So that is the importance. That's why if we look on a human body, like this is a little bit more plastic surgery, the skin cleavage lines are running that particular direction. And if we can, whenever we can, we want to cut the skin in this particular manner. So, and that is what we want, hey? So just more like if we cut the skin here, if we cut the skin like that, we have a much prettier scar along the neck. Let's cut along the cleavage line so that it is a lot neat and tidy and easier scar. So don't forget these cleavage line whenever you are going to make a cut on somebody's skin. So these are important. So in the neck, go circumferential. In the tummy, go circumferential. In the limb, a little bit more oblique, or if you can. If not, please go longitudinal in the leg. So these are the important skin cleavage line. So that's why, some surgical incisions are much easier to cope with comparing to many others. So this is a Fenesty incision. So it is just like across your pubic bone, just above the pubic bone, like about 1 finger breadth, 2 finger breadth, and then it's just cut along here. So Fenesty incision, which is usually used for the obstetrics or gynecology procedure or urology procedure. So yes, this is very, very good scar. It is going to give you a very good scar. And this Kocher's incision, it's okay. But let's say, if you can, like, just please go like a horizontal. These gridirons and lens incision, these cuts are for the appendix operation. So appendicular, so lens incision, which is more horizontal, will be better than gridiron incision. So lens incision is more a later modification of gridiron incision, which will give us a much better scar. So why do we think and why do we cut this direction of skin? It is because of the underlying dermal collagen fibers, which give us the cleavage line. Right. So if we are making a cut on the, like a longitudinally on the tummy, the scar is not going to be as good as the previous scar, like a Fenesti incision. So why? Everyone knows it to good extent that we don't want to do this sort of scar. But why do we have to do this? In case of emergency, and if we want to open the whole abdomen, we have to cut like that in the center, get the whole of tummy empty. Because if we cut like that in this area, we won't be able to reach the top organs around here. And therefore, sometimes, in case of emergency, we are not sure what is happening in someone's tummy, and we need to see everything in the abdomen. Hey, let's go for the longitudinal mid-sagittal incision, yeah, median incision or mid-sagittal incision, and let's go through it. We don't have time. We need to see all the abdominal content from the top end, epigastrium, to the hypogastrium. You have no choice. You have to cut it, open it up, see everything, and then walk out. Later problem is again. So this is all about the skin knowledge. And I don't want you to forget about this moral level lesion, moral level mechanism. So what is the moral level mechanism? Look at this patient. This patient is pretty huge patient, like the skin, this is the tummy, this is the thigh, and this is the knee, and on other side, there will be the leg. So this is the knee joint, this is the leg, this is the thigh, which is very much swollen. This is the tummy. The patient is on the operating table, which is well draped and prepped. And you can see the skin abrasion and big swelling underneath. So how do we usually get this picture? So usually, like a high energy injury, for example, like motorcyclists, high speed, thrown off from the motorbike, just come in with the multiple injuries. And when he came in, so we can see only the little grace, abrasion on this skin. So no one appreciate much. But what really happened is this part of the skin, both epidermis and dermis, has glide on top of each other over the hypodermis. And in that region, there is, so all the blood vessels supplying from the underneath of the body. So from the muscle, hypodermis to dermis. So all the blood vessels has been damaged. It's a shear force. Because of the shear, epidermis and dermis gliding, or a hypodermis gliding on top of each other. All these blood vessels have come in. There is a bleeding underneath. That is what we call moral level lesion, which is really significant problem because the overlying skin here, epidermis and dermis, lost blood supply from the deeper structure, and it is like a cushion bump sitting in between. With time, the skin on top of this lost blood supply and then die, necrosis. And if we lost such a big area of skin, it is going to be a disaster. So that is what important about moral level lesion. So if you are walking in an emergency department, you will just see the trauma patient come in. You will just see, big grace over the thigh, and the patient want to theater for many different regions, and then it will end up in the intensive care unit. After 2-3 days, the intensive care people, they start noting, hey, what is going on here? This leg becomes swollen and swollen. The skin grays, the skin is starting to die and peeling off. That is one thing we should remember. Hey, this could be a moral level lesion. So we have, if we do an ultrasound scan, we can see a large fluid collection in the underneath the skin, epidermis and dermis. So that is important about moral level lesion. So now we finish with the skin, which is epidermis, dermis, and hypodermis. Let's go to the skin appendages. Let's go to the skin appendages. So they are like hair follicle, nail, sebaceous gland, and sweat gland. Yeah, we'll talk about these. So nail, what is a nail? A nail is a keratinizer, which is death. So these keratin die out and it is hardened. It is just like, you know, if you bake a cake, it's moist and soft. And if you dehydrate that cake, you will get a biscuit. That's a very rough idea. So the same thing, if your skin is soft, nice, moist, with overlying keratin, that is skin. If you dehydrate that skin, only the keratin left, dense, thick, hard keratin, then you will get a nail. So the nail is nothing more than the dead keratinizers. So it is a hard keratin. It is not the soft keratin we have on our skin. It is much harder keratin, which are nail and hair. Soft keratin will be used in the epidermis cell. So the skin keratin is soft. The nail and hair keratin is harder. But these keratins are dead already. So I want you to remember a few little things here. Because if you walk in urgent care, if somebody damaged their nail bed, and you need to interpret what structures are damaged, what is the language of this nail injury? Because you might be speaking to the plastic surgeons to repair the nail. You might be speaking to the, or you might be sending home. So if you want to speak to the more specialized hand surgeon or finger or plastic surgeons, you are going to communicate well if you can remember these little terminology. So the free edge of the nail, it is so easy to remember, the nail's free edge. And this nail we can see is called nail plate. So the nail plate is extending and finish as the free edge of the nail. The origin of the nail here, the nail is pink color. You can see that our nails are pink because it is so thin out. We can see the blood vessels underneath the nail plate. That's why the nail, this area is pink. And the nail is sitting on a surface which is called nail bed. So we have the bone here and the blood vessels here. There is a surface area which the nail sits on. It is called nail bed. And on top of that, the nail plate will sit. The nail plate, if you trace the nail plate, and you will get the origin of the nail, which is called root of the nail or nail root. And the nail root came from the nail matrix. This is the nail matrix, is the area of the generating nail. So the root is generating all the dead keratin. So the nail matrix makes the nail. So in this area here, the eponychium and lunar area is little like a moon, lunar moon. It's little like a half moon shape, you know, and this area is a little bit wide out. Why is that? Because the underlying nail bed became much thicker, and you lost seeing the blood vessels. Therefore, this area is pink and this area is more or less white area. And the importance of the nail matrix is if somebody damaged their nail, and if they damage the nail matrix, so where the root of the nail, where the generating portion of the nail is damaged, they can get, the nail might not grow, or the nail will grow in a little different shape or cracked nail. That sort of things happen. So nail matrix is important. nail root is here, and the nail plate is all along, which we cut every, and nail plate is sitting on top of the nail bed, and that is the free edge of the nail, and the side portion of the nail is called peronicium, and the upper portion where this underneath the skin is called eponychium. So eponychium, peronicium, nail plate, nail bed, nail matrix, nail root, and free edge of the nail. So these are the little terminology. I hope it is not too difficult, which will help you to communicate with some other clinicians. So let's say if you are studying as a young staff in the urgent care, and if you do not understand, you are going to speak to your senior. And when you speak to the senior, if you know these terminology, it will be a lot easier. So appendages of the skin, nail, hair follicle, sweat gland, and sebaceous gland. So let's talk about hair. Of course, we are not the hair transplant person, so we will not talk that far, but at least we need to understand our hair to basic extent. So the hair, if you do a cross section of our hair, there are like 3 main layers, 3 concentric structure of keratinized cells. So here, this is the hair. Look at that hair. In the center, in the very center, it is called medulla. Medulla's portion of the hair is covered by the outer layer, which is called cortex. Cortex and medulla, you are going to see this terminology off and on. And brain, outer cortex, inner medulla, adrenal gland, cortex, and medulla. So inner portion is medulla, outer portion is cortex. So that is hair. It is so detailed. Our hair is very small, and it is very much detailed about the hair. So let's say very inner portion is medulla, and medulla portion is covered by the outer cortex. The outermost portion is called cuticle. So these are the portion of the hair. They will be, if there is in the follicle, this hair will be surrounded by the root sheath, and there will be and there will be in general there will be a big follicle here. So that is it really important? Not really, but once you have a chance, grab this knowledge. At least if you take your hair without the root, at least you remember you have the 3 portion, inner medulla, which is surrounded by outer cortex, and very out there is cuticle. And look at that, this hair is pretty much rounded. So if you have a round hair, your hairs are strong and spiking like that. If your hairs are a little bit flat, not as rounded, but a little bit flat, your hairs are a little bit wavy. If your hair is really, really flat, then it will become conch like that. So there are 3, like 100% circular will give you a sharp and pointy hair. So some people do have very strong hair. Their hairs are very much pointy because if you look at carefully, the hair is very much circular. If they're a little bit oblique, flatten a little bit, then the hair will be a little bit wavy. And if the hair is too flat like that, it is very kinky. So those people who do not have a strong hair, the hairs are flat and they are very kinky. So this is the hair root. So the origin of the hair, as we know, we can see the medulla portion of the hair, outer cortex of the hair, and outermost cuticle portion of the hair, which are surrounded by the different layers as we go along. So that is all about hair and hair follicle. I don't want you to give too much. And sweat glands. Let's talk about sweat gland. Sweat gland can be divided into two, eccrine gland and apocrine gland. So there are two different types of sweat gland, eccrine and apocrine. Nearly every part of our body, like forehead, the palm of the hand, or the sole of the feet, or the armpit, or here, every portion of our body has some type of sweat gland. It can be either eccrine gland or apocrine gland. Eccrine gland is more common, like most of the sweat gland in our body, they are eccrine gland. They are what we call like sodium chloride and water. These are the like sweat on our forehead that is coming from the eccrine sweat gland. So what is about apocrine sweat gland? Apocrine sweat gland, these are a little bit more particular. And these apocrine glands, you can see like, especially in the armpit, in the groin, in the genitalia region or anus region. So apocrine glands are a little bit more specialized. They are not everywhere. So apocrine glands like sebum, sebaceous gland, might open into the apocrine sweat gland as well. So that, and these become a little bit more prominent after the puberty. So this, because of the hormone, because of the sebum, and the area like armpit or your perineum, so that gives you the particular smell, which is what we call homophone, like the little bit sense of sex and that sort of stuff, that sort of sensations you get. That is very much particular to your body, and that makes your smell mainly. So that is the difference between your eccrine gland and the apocrine gland. So let's look at that. This is a tattoo. Has anyone got tattoo? Yes, I believe, many people have a little bit of tattoo, like here and there, might be hiding. So what is the tattoo? Tattoo, these are the little pigments stick into the dermis layer of the skin. So it is not in the epidermis, because if you put these pigments into the epidermis, what will happen? They will just shed and renewed. So because epidermis is changing, like every 6 to 8 weeks, we have new skin. Every 8 to 6 weeks, we have new skin. So epidermis, so if you are a little bit careful, then you might want to put your tattoo in the epidermis so that after 2-3 months, it might disappear, because epidermis will cycle will complete after 6 to 8 weeks. But because tattoo is so permanent, these little pigments are injected into the dermis, because dermis not change, so they will stay with us for life. So if you do not want something permanent, don't get a tattoo, because it is so difficult to remove. Like, some people, they just go into the dermis and just try it. You end up with spending lots of money, and it might not be successful, and it might create more scars. So just before you do a tattoo, just think a little bit, do I really want this on my body for the rest of our life? So anyway, in short, tattoo is the pigments, the yellow pigment, blue pigment, red pigment injected into the dermal layer of the skin. So these are what can we go wrong with this, our skin? Of course, we see the burns injury. And if you look at this diagram, this photo, this is the elderly patient. Around the nose, the face is exposed to the sunlight. And you see a little nodule-like swelling with a little umbilicated central portion. It is a little pearly white, like a pearly white structure, little bit raised, and with the central umbilication in the sun-exposed area, Like usually the picture they will say is, hey, this person is a farmer from Texas. So that means like he is exposed to the sunlight in a hot region. So doesn't really need to be exposed to sunlight that much, but that is the very typical expression. And you can see this little pearly white raised nodule with central embellication. If you see that, just be careful. Hey, it could be basal cell carcinoma, so cancer of the skin, one form of skin cancer. And this is squamous cell carcinoma. So skin epithelium is squamous epithelium, multiple layer, stratified squamous epithelium. So this, and you start seeing the ulcer, which is not healing properly. Then it could be a squamous cancer. Of course, we all remember the mole and melanoma. This is the cancer of the very common cancer, the malignant melanoma. This is melanoma. Melanoma, oma means tumor, melanoma means melan from the melanocytes. So these are a few little things which can go wrong on our skin. And don't forget, skin is nothing more than this, which is made of epidermis and dermis, isn't it? The same, this picture. And sebaceous and sweat gland. Some of the sebaceous gland and sweat gland, they go into the epithelium of the hair follicle root. But these sebaceous glands, they are in the dermal region, especially in the reticular dermis region. These are the. So now, finally come to the near end of our lecture. This is our skin, which is something like that, which is really important. So don't burn your skin. Look after your skin. Don't expose to the sun too much if you can, because the skin will protect you, and it is for the rest of your life. Whether you are dark or you're white or you're colored, doesn't really matter. Whether you're tall or short, doesn't really matter. This skin will protect you for the rest of your life. And that is really important. So now we have taken skin off, and we have taken all the muscles off from our body. And now we got a skeleton. So as we see, this is on our left or on the right of the diagram is the male body, and on the left is female body. So this is the male skeleton, and this is the female skeleton. Ha ha ha. So what is the big deal? What is the big difference between male and female skeleton? So if you look at the pelvis is a little bit more vertical and a little bit narrow, but more long. So the pelvis is different. You can see that male pelvis is long and narrow. Look at the female pelvis. It is not as long as male pelvis, and it is wide. Look at the width of the pelvis here to there and here to there. So female pelvis is much wider and male pelvis is much narrower. Female pelvis is a little bit short, male pelvis can be longer. So that is a difference between the male pelvis and female pelvis. And so when you do the forensic, if you see a bony specimen and you start thinking, is it a male or female? Then you have to look at the pelvis. And if the pelvis is wide, it could be female. If the pelvis is narrow, it could be male. But of course, it's not 100%, but that is something we can think about. And look at the pelvis outlet. It is really like a sharp angle, acute angle. And female pelvis is much wider angle. Of course, for the childbirth, we need a much wider pelvic outlet, much wider pelvic brim, and need to be a little bit shallow as much as we can. So that is the difference between male pelvis and female pelvis. So now we will start talking about a little bit about the bones of the skeleton. Hey, this is our humerus, so our arm bone, humerus, easy. The skeletons, they are in anatomical position. This is the radius, which is on the lateral side. In the forearm, we have two bones. Lateral is radius and medial is ulnar. So radius, ulnar, and humerus. I believe you all know this already. And in the leg, we got a big femur. Everyone knows femur. And in the leg portion, we have a big bone, which we can easily feel. It is called tibia. And small little bone, which is on the lateral to the tibia. Lateral to the tibia is small little bone, which we call fibula. So most of the body weight, about 75–80% of our body weight, will go along the femur and along the tibia. So only about 20% of the body weight might go through the fibula. So fibula is not a major important bone for the weight bearing, but it gives muscle attachment. So in the forearm and in the leg, we have two bones each, tibia and fibula, and radius and ulnar. And look at that male and female pelvis. Male pelvis is very acute angle. Female pelvis is very wide angle. Of course, it is important for the childbirth. And if you look at that, male pelvis is narrow, female pelvis is wide. Female pelvis is short, male pelvis can be long. So these are the little difference between male and female pelvis. And this is the shoulder girdle. So this is your humerus, H, and these are the ribs. And this is the shoulder girdle. And you are seeing the clavicle, which is our collarbone here. This is the left clavicle, and this is the right clavicle. And this is the wing bone, which we can see on the back triangular bone, which is what we call scapula. Scapula is the wing bone. So from today onwards, I have told you this is scapula, and therefore we are not going to talk wing bone. It is for the layman term. It is for the layman term. And we will be more talking like scapula. Yeah, we'll be more talking like scapula. And this is the humerus and scapula will form shoulder joint. If you look more carefully, this is the head portion of the humerus. This is the clavicle, collarbone, and this is acromion, which is the projection coming from the scapula. Of course, we can repeat again and again, and this is the anterior projection of the scapula, which is what we call coracoid process. And looking at the human body, which is in anatomical position, you are looking from the back and the right side of the body, and this is the scapula. The posterior portion of the scapula has the spine here, which split the scapula into supraspinous region and infraspinous region. The portion of the scapula which articulate with the head of the humerus is called glenoid. So acromion, which we saw here, acromion, anterior projection from the scapula. So scapula, in short, has anterior projection, which is what we see, coracoid process, and here spine of the scapula and anterior projection called acromion. Acromion and the clavicle form a joint, which is what we call acromioclavicular joint. And this is the, you are now gradually turning to the back side of the skeleton. And this is the right scapula, and this is the left scapula. And you can see the spine of the scapula projecting forward as the acromion, and we are still seeing the clavicle, and this is the acromioclavicular joint. All right, guys. I hope this is not too much for you guys. Has anyone got any question? All right. So in that case, if you can just unmute and say thank you and goodbye to everyone.
Thank you, Professor.
Thank you.
Yeah.
Thank you.
Have you got any question, anything else?
I'll probably have to see it again.
Yeah, I know. I will post the lecture. Yeah.
Definitely.
Yeah.